Hey everyone, and welcome back for another deep dive. Today we are taking a closer look at a topic that's super important for nursing students and faculty, pregnancy complications.
Yeah, absolutely.
We're talking about the things you need to know to, really ace those exams and impress in clinicals.
Yeah, really nail down that core content.
Exactly.
Yeah.
And it's all straight from that nursing textbook you sent over.
Perfect.
So we'll cover, some of the more well-known pregnancy complications, but we'll also, dig into some of the less common stuff too.
Right, like choriocarcinoma.
Choriocarcinoma,
Yeah.
yep. Or
Hydramnios.
yeah, those are great examples.
Really important stuff, because ultimately we're talking about the health of both the mom and the baby.
Of course, that's always the priority.
Right. And as nurses, we have a big responsibility to, make sure things go as smoothly as possible.
Absolutely. We play a critical role.
Okay, so first up, we've got bleeding during pregnancy.
Oh, okay.
Now, this is a big one because it can happen at any point during pregnancy, and it's always a potential emergency. Absolutely every minute counts.
Yeah, you got to be ready to act fast.
Yeah.
So about 25% of women experience bleeding in the first trimester.
Really? Wow, that many.
Yeah, it's more common than you might think.
Huh, interesting.
So what are some of the things that can cause bleeding in early pregnancy?
Well, there's spontaneous abortion,
Mm-hmm.
ectopic pregnancy, gestational trophoblastic disease,
Right.
cervical insufficiency.
Okay, and later in pregnancy.
Later on, you might see bleeding from placenta previa or placental abruption.
Okay, so let's break those down a little bit.
Yeah.
Let's start with ectopic pregnancy because that one can be really dangerous.
Definitely, it's a leading cause of maternal death in the first trimester.
Wow.
Yeah. So you need to be able to recognize it quickly and get that patient the right care.
So what are the signs?
The classic triad is abdominal pain, amenorrhea, and vaginal bleeding.
Okay.
But here's the thing, only about half of women experience all three of those symptoms.
So it's not always so clear-cut.
Right, exactly. It can be tricky.
So are there any other risk factors we should be aware of?
Oh yeah, definitely. A history of pelvic inflammatory disease or a previous ectopic pregnancy definitely increases the risk.
Okay.
And this is an interesting one. Exposure to a drug called diethylstilbestrol, or DES, has also been linked to ectopic pregnancies.
DES. I vaguely remember learning about that.
Yeah.
What is it exactly?
It was actually prescribed to prevent miscarriages back in the day.
Really?
Yeah. But it turned out to have some pretty serious long-term side effects.
Wow. So sometimes what we think is helpful can actually backfire in unexpected ways.
That's a great point. Medicine is constantly evolving.
Right. So going back to bleeding later in pregnancy,
Yeah.
we mentioned placental abruption before.
Yeah.
Can you explain what that is?
Sure. So placental abruption is when the placenta starts to detach from the uterine wall,
Okay.
and this can be extremely dangerous for both the mom and the baby.
How so?
Well, for one thing, there's a risk of hemorrhage,
Right.
and the baby might not be getting enough oxygen or nutrients if the placenta is detached.
That makes sense.
Yeah.
And you mentioned there are different grades of placental abruption?
Right. Yeah. There are 3 grades, with grade 3 being the most severe. It can lead to profound shock,
Oh, wow.
and even something called DIC.
DIC. What's that?
DIC stands for disseminated intravascular coagulation. It's a clotting disorder that can be life-threatening.
Oh, wow. That sounds scary.
It is. And here's something that might help you remember it. The bleeding associated with placental abruption often has a distinct port wine color.
Port wine color. Interesting.
Yeah, it's a kind of a dark purplish red.
Okay. I'll try to remember that.
Another really important thing to note is that a woman can lose up to 40% of her blood volume before showing the typical signs of shock.
40%.
Wow.
Yeah.
So you really have to be on top of things and monitor these patients super closely.
Definitely no room for error with this one.
Agreed.
Yeah.
Okay, so let's move on from bleeding and talk about another condition that can be really tough on pregnant women, hyperemesis gravidarum.
Oh, yeah. I've heard of that. It's like morning sickness on steroids, right?
Yeah, that's a good way to put it. Most people are familiar with morning sickness, but hyperemesis gravidarum is way more severe.
How so?
We're talking about persistent nausea and vomiting that can lead to dehydration, weight loss, electrolyte imbalances.
Oh, wow.
And it often requires hospitalization.
So how do we know when it's crossed the line from regular morning sickness to hyperemesis gravidarum?
Well, one key indicator is weight loss. If a woman loses more than 5% of her pre-pregnancy weight, that's a big red flag.
Okay, 5% weight loss. Got it.
Mm.
And what causes it?
That's a good question. The exact causes are still being debated, but it seems to be a combination of Things, hormonal changes, metabolic factors, maybe even some genetic predispositions.
So it's another one of those multifactorial things.
Exactly. Pregnancy complications are rarely simple.
Okay, well, let's move on to another complex one. Hypertensive disorders of pregnancy.
All right.
Now, I know there are a few different types of hypertension that can occur during pregnancy.
Right. So first we need to differentiate between chronic hypertension, which is high blood pressure that was present before the pregnancy, and gestational hypertension, which develops during pregnancy.
Okay, makes sense. And then there's preeclampsia and eclampsia, which are kind of in a category of their own.
Absolutely. Those are serious conditions.
Yeah, they can be life-threatening.
Right. Unfortunately, yes, preeclampsia is a leading cause of maternal death worldwide.
Wow, so tell me about preeclampsia. What exactly is happening in the body?
It's basically a two-stage process.
Okay.
First, you have vasospasm, which means the blood vessels are narrowing. And then you get the classic symptoms like high blood pressure and protein in the urine.
So how is preeclampsia different from eclampsia?
The key difference is that eclampsia involves seizures.
Okay, so preeclampsia is like the precursor to eclampsia.
You could say that, yeah.
Yeah.
But it's important to remember that preeclampsia itself can be very serious.
Right, it's not something to take lightly.
Definitely. And we also need to talk about HELLP syndrome, which is a severe complication of preeclampsia.
HELLP syndrome. I remember learning about that one. What does HELP stand for again?
It stands for hemolysis, elevated liver enzymes, and low platelets.
Oh, right. I remember now. So it affects multiple organ systems.
Exactly. It's a serious condition that requires prompt recognition and treatment.
So what do we do for preeclampsia? I've heard that magnesium sulfate is often used.
That's right. Magnesium sulfate is a really important medication for preventing seizures in women with preeclampsia.
But it can also be toxic. Yeah.
That's true. So we need to monitor these patients very closely for signs of magnesium toxicity like respiratory depression, absent reflexes, and low urine output.
It's all about finding that balance between effectiveness and safety.
Exactly.
All right, so moving on. Let's talk about blood incompatibility. Specifically, RH incompatibility.
Okay.
This one always takes me back to immunology class.
It's a fascinating topic and really important in obstetrics.
So remind me how it works again.
Basically, if an Rh-negative mother is carrying an Rh-positive fetus, there's a risk that her immune system will see the baby's Rh factor as foreign.
And her body will start producing antibodies against it.
Exactly. And those antibodies can cross the placenta and attack the baby's red blood cells, which can lead to a condition called hemolytic disease of the newborn.
Right, and that can be really serious.
It can be. Fortunately, we have a way to prevent this from happening.
How's that?
We use a medication called Rojam, which is Rh immunoglobulin.
Oh, right, Rojam.
Yeah.
So how did that work?
It basically prevents the mother's immune system from becoming sensitized to the Rh factor.
So it's like a protective shield for the baby.
You could think of it that way. It's really an amazing medication.
It really shows how far we've come in terms of preventing complications.
Absolutely. Okay, so let's touch on amniotic fluid imbalances.
Okay.
We've got two extremes here. Polyhydramnios, which is too much amniotic fluid, and oligohydramnios, which is too little.
Okay, so what are the main things we need to know about these conditions?
Well, both extremes can cause problems for the baby.
In what way?
Too much amniotic fluid can put pressure on the mother's diaphragm, making it hard to breathe. It can also lead to preterm labor.
Okay.
And too little amniotic fluid can cause problems with fetal growth and development.
I see. So we want to make sure the amniotic fluid levels are just right.
Exactly. Goldilocks and the three bears.
Right. Not too much, not too little.
Perfect. Okay, next up, multiple gestations.
Twins, triplets, all that fun stuff.
Right. Well, it is fun, but it also comes with increased risks.
Oh, yeah, for sure. What kind of risks are we talking about?
Well, the mother is more likely to develop anemia, hypertension, preterm labor.
Okay.
And the babies are at higher risk of being born prematurely, having a low birth weight, and experiencing complications related to prematurity.
Right. It makes sense that there would be more challenges with multiples.
Absolutely.
Yeah.
Okay, last one for this part of our deep dive, pre-labor rupture of membranes, or PROM.
PROM. Okay.
And this is when the amniotic sac breaks before labor starts.
The outer breaks.
Exactly.
And that can happen prematurely, too.
It can. And that's called PPROM, preterm pre-labor rupture of membranes.
Okay, so what's the big concern with PROM?
The main concern is infection. Once the membranes rupture, it creates a pathway for bacteria to enter the uterus.
Oh, I see. So how do we know if a woman has PROM?
There are a few tests we can do, like the nitrazine test and the Fern test.
Okay, what are those?
The nitrazine test checks the pH of the fluid, and the Fern test looks for a characteristic fern-like pattern when the fluid dries on a slide.
Huh, interesting.
And treatment depends on how far along the pregnancy is and whether there are signs of infection.
So if the baby is close to term and everything looks good, we might just go ahead and induce labor.
Right.
But if the baby is premature, we might try to prolong the pregnancy as long as possible.
Exactly. We want to give those little lungs time to mature.
Makes sense. Wow, we've covered a lot of ground already.
We have. And there's still more to come. But I think this is a good place to pause for now.
Yeah, let's take a break and come back for part 2.
Sounds good. So we covered a lot in part 1.
We did a lot of heavy-hitting stuff.
Really important stuff.
Yeah. So before we jump into the next batch of complications, maybe we should...
Do a little recap.
Yeah, a quick recap to kind of, refresh everyone's memory.
Sounds good to me. So we started by talking about bleeding during pregnancy.
Right, and how it's always a situation that requires,
Careful assessment.
Right.
We talked about the difference between bleeding in early pregnancy, which could be, a miscarriage or an ectopic pregnancy,
Right.
and bleeding later in pregnancy, which might indicate something like placenta previa or placental abruption.
Which can be really, really serious.
Definitely.
That port wine color that you mentioned?
Oh, yeah.
That's going to stick with me.
It's a good visual.
Yeah, for sure. So then we talked about hyperemesis gravidarum.
Yes, that one's tough.
Yeah, it's more than just morning sickness.
Oh, yeah, way more severe. It
Yeah.
can have a huge impact on the mom's health.
I remember that 5% weight loss.
Mm-hmm.
That's a key thing to remember.
Absolutely.
If a woman loses more than 5% of her pre-pregnancy weight,
That's a sign that something's not right.
yeah, it's time to intervene.
Yeah.
And then we talked about all the hypertensive disorders.
Oh, yeah, that's a whole world unto itself.
Chronic hypertension, gestational hypertension,
Preeclampsia, eclampsia.
and of course, HELP syndrome.
Right, all those fun acronyms.
Yeah, I love them. But really, though, those are serious conditions.
Absolutely life-threatening in some cases.
Yeah, so we talked about magnesium sulfate for preeclampsia.
Which is a great medication, but,
It's got that narrow therapeutic range.
Exactly. You got to be super careful with the dosing and monitor those patients closely.
For sure. Then we talked about RH incompatibility.
Another fun one.
With all those antibodies floating around.
Right. But the good news is we've got Rogam to prevent those complications.
Rogam's a lifesaver for sure. Oh, and then we talked about amniotic fluid imbalances.
Too much or too little can both be bad.
Yeah, we want that sweet spot.
Goldilocks.
Exactly. And finally, we wrapped up with multiple gestations and PROM.
Lots of important stuff to know.
Definitely. Okay, so I think we're ready for part 2.
All right, let's do it.
So you mentioned placenta previa earlier.
Yeah.
That's when the placenta covers the cervix, right?
Partly or completely?
Okay, so what does that mean for labor and delivery?
Well, if the placenta is covering the cervix, vaginal delivery is usually not possible.
Because of the bleeding.
Right, there's a high risk of hemorrhage.
So a C-section is the way to go.
Yep, in most cases.
Okay, let's talk about cervical insufficiency now.
Okay.
This one sounds kind of scary.
It can be. It's basically a weakness in the cervix that causes it to open prematurely.
Prematurely, so before the baby is ready to be born.
Exactly. And that can lead to miscarriage or a very preterm delivery.
Which obviously has serious consequences for the baby.
Absolutely. So it's something we definitely want to catch early.
So what causes it?
That's a good question. Sometimes the exact cause is unknown, but it can be related to previous trauma to the cervix.
Trauma like what?
Like a cone biopsy or a difficult delivery with a lot of tearing.
So it's important to ask about that in the history.
Definitely. And we can also use transvaginal ultrasound to measure the length of the cervix.
Okay.
That helps us identify any signs of shortening or funneling.
Funneling? What's that?
It's when the cervix starts to open from the inside out.
Oh, I get it. And what do we do if we diagnose cervical insufficiency?
Well, we often recommend bed rest and pelvic rest.
Okay.
And sometimes we might do a procedure called a cervical cerclage.
A cerclage? What's that?
It's basically a stitch that we put around the cervix to keep it closed.
Oh, like a little reinforcement.
Exactly.
Okay, next up, placenta creta spectrum.
This one's a bit more complex.
What is it exactly?
It's a group of conditions where the placenta attaches too deeply into the uterine wall.
Too deeply, so it's not just a normal attachment.
Right. In the most severe form, placenta percreta, the placenta can actually grow through the uterine wall.
Through the uterine wall. Wow.
Yeah, and it can even invade nearby organs like the bladder.
That sounds really dangerous.
It can be. It can cause massive bleeding during delivery.
Oh, wow.
And often a hysterectomy is needed to control the bleeding.
So this is a serious complication.
Very serious. And unfortunately, we're seeing it more and more these days.
Why is that?
One of the main risk factors is previous cesarean deliveries.
Really?
Yeah. The more C-sections a woman has had, the higher her risk.
Wow. That's something to keep in mind.
Definitely. Okay, so let's revisit morning sickness, and hyperemesis gravidarum.
Okay.
We talked about the 5% weight loss threshold before.
Right.
But I want to touch on some of the treatment options.
Okay, so what can we do for women who are really struggling with nausea and vomiting?
Well, first-line approaches often involve dietary and lifestyle modifications.
Like eating smaller, more frequent meals.
Exactly. And avoiding trigger foods.
And I know there are some home remedies that people swear by.
Oh, yeah, ginger peppermint.
Right, things like that.
Those can be helpful for some women, but in severe cases, hospitalization might be necessary.
To give IV fluids and medications.
Right. We need to correct those electrolyte imbalances and get the vomiting under control.
Okay, that makes sense. Now let's talk about polyhydramnios and oligohydramnios again. We talked about the potential consequences of too much or too little amniotic fluid.
Right.
What about management?
Well, with polyhydramnios, we might do a procedure called amnioreduction.
Amnioreduction.
Yeah, it's basically removing some of the excess amniotic fluid.
Oh, okay. And what about oligohydramnios?
For that, we might do an amnioinfusion.
Amnioinfusion.
That's the opposite of amnioreduction. We infuse fluid into the uterus.
To replenish the amniotic fluid.
Exactly.
Interesting. Okay, let's talk about PROM again. Pre-labor rupture of membranes.
Okay.
We know that infection is a big concern.
Definitely.
So what are the key things we need to remember when caring for a patient with PROM?
Close monitoring is essential. We need to watch for any signs of infection.
Like fever.
Fever, increased heart rate, foul-smelling vaginal discharge.
Right, those are all red flags.
Absolutely.
Right.
We also need to assess the gestational age because that will guide our management decisions.
Right, so if the baby is close to term, we might induce labor.
Exactly.
But if the baby is premature, we'll try to prolong the pregnancy.
And give the baby steroids to help mature the lungs.
Okay, it sounds like a lot of careful decision-making goes into managing these cases.
It does. You have to weigh the risks and benefits very carefully.
Well, this has been a whirlwind of information, but really helpful stuff.
I'm glad you think so. We've covered a lot of ground.
We have. So what are your key takeaways from this second part?
Well, I think it's amazing how many different things can go wrong during pregnancy.
Right. It really highlights the complexity of the whole process.
Exactly. And it shows how important it is to have skilled nurses who can recognize these complications and act quickly.
Couldn't agree more.
We also talked about the importance of patient education and shared decision-making.
Oh, yeah, that's huge.
We need to make sure our patients understand their options and feel empowered to participate in their care.
Definitely. So before we move on to the final part of our deep dive,
Okay.
I want to leave our listeners with something to think about.
Okay.
We've talked a lot about the medical aspects of these complications. But what about the emotional and psychological impact on the mother and her family?
Oh, that's so important. Pregnancy complications can be incredibly stressful and traumatic.
Absolutely.
Yeah.
So we need to provide holistic care that addresses the emotional and psychosocial needs of our patients as well.
I completely agree. We can't forget about the human side of things.
Compassion, empathy, a listening ear.
All of that is so important.
Well said. Okay, so are you ready to tackle the last few complications?
Bring it on. Let's do it.
Okay, so we're back for the final part of our deep dive, and we've got a few more complications to cover before we wrap things up.
Right. We left off with that thought-provoking question about the emotional and psychological impact of pregnancy complications.
Yeah, it's so important to consider the whole patient, not just the physical symptoms.
Absolutely. So let's jump into those last few topics, starting with gestational trophoblastic disease, or GTD.
GTD, okay.
This one can be a bit tricky to understand, but it's important to know the basics.
Okay, so what is GTD exactly?
It's a group of rare conditions that occur when cells that would normally form the placenta start to grow abnormally.
So it's like the placenta goes rogue.
In a way, yeah. One type of GTD you might have heard of is a hydatidiform mole, sometimes called a molar pregnancy.
A molar pregnancy? What's that?
It's a type of pregnancy where a fertilized egg doesn't develop properly. Instead of a normal embryo, a mass of abnormal tissue grows inside the uterus.
There's no baby.
No viable fetus.
Oh, wow. So what happens?
Well, this tissue can actually grow quite rapidly and can even become invasive.
Invasive.
Yeah, meaning it can grow into the uterine wall or even spread to other organs.
Oh, wow. That's scary.
It can be. So close monitoring is really important.
Okay, so how is GTD treated?
Usually it involves a procedure called a dilation and curettage, or D&C, to remove the molar tissue.
Okay, and then what?
We monitor the woman's HCG levels very closely.
HCG, that's the pregnancy hormone, right?
Exactly. We want to make sure the levels go back down to normal, which indicates that all the abnormal tissue is gone.
And if they don't?
It could mean that some of the molar tissue remains or that it has become cancerous, which is a possibility with certain types of GTD.
So chemotherapy might be necessary.
It might be.
Okay, well, that's a lot to process.
It is. But the good news is that GTD is relatively rare.
That's good to know. Okay, let's move on to something a little more common, preeclampsia.
All right, preeclampsia. It's the big one.
We talked about it earlier, but I think it's worth revisiting.
I agree. It's so important for nurses to understand.
So just to recap, preeclampsia is characterized by high blood pressure and protein in the urine.
Right. But it can also involve a lot of other symptoms and complications.
And it can progress to eclampsia, which is even more serious.
Exactly. Eclampsia involves seizures, which can be life-threatening.
So it's really important to catch preeclampsia early.
Absolutely. What are some of the things we should be looking for?
High blood pressure, obviously. Protein in the urine.
Right.
And I think swelling is another sign.
It can be. Sudden weight gain, swelling in the hands and face are all potential red flags.
And what about headaches?
Headaches, especially persistent headaches, can be a sign of preeclampsia.
Okay, and vision changes.
Yes. Things like blurry vision or seeing spots can also be warning signs.
So basically, any unusual symptoms should be taken seriously.
Exactly. It's always better to err on the side of caution.
So what can we do to manage preeclampsia?
Well, it depends on the severity. But the main goal is to control the blood pressure and prevent seizures.
And sometimes bed rest is recommended.
Bed rest used to be the standard of care, but we've kind of moved away from that.
Really? Why is that?
Research has shown that it's not always necessary or beneficial. The focus now is on individualized management.
So what does that look like?
It might involve close monitoring at home or in the hospital, depending on the situation.
Okay, and medications.
We might prescribe medications to lower the blood pressure, and of course we already talked about magnesium sulfate for seizure prevention.
Right, magnesium sulfate. Powerful stuff.
It is, but we have to be careful with it.
Definitely. So what's the ultimate cure for preeclampsia?
Delivery of the baby.
Oh, okay, so once the baby is born, the preeclampsia resolves.
In most cases, yes.
Okay, that makes sense.
Yeah.
So it's all about getting the mom and baby safely to that point.
Exactly.
Well, this has been a pretty intense deep dive.
It has. We've covered a lot of ground.
But it's so important for nurses to have this knowledge.
I agree. It can literally mean the difference between life and death for some patients.
No pressure, right?
Well, there's always pressure in nursing, but that's what makes it so rewarding.
That's true. So any final thoughts before we wrap things up?
I just want to emphasize that the world of obstetrics is constantly changing. So it's important to stay up to date on the latest research and guidelines.
Right. Never stop learning.
Exactly. And never underestimate the power of a good nursing assessment.
So true. Well, I think that's a great note to end on.
It is.
Thanks for joining us for this deep dive into pregnancy complications. And we'll see you next time.
Bye, everyone.